Hello, everyone. My name is Kate Foster, and I'm the account manager at IHEA. Welcome, and thank you so much for registering for today's workshop, Valuing Health for Children, Adults, and Caregivers, Lessons Learned from COVID-19. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on our website afterwards. Before we begin the webinar, I'll quickly run through a couple housekeeping items. If you experience any technical issues during today's webinar, please write them in the chat box at the bottom of your screen, and I'll be happy to assist. Everyone on the line has been muted in an effort to eliminate background noise, but if you'd like to speak aloud, please feel free to use the raise your hand function and unmute. I will now pass it over to our convener, Stavros. Stavros, over to you.
Thanks very much, Kate, and welcome everyone. This is the third of this year's IHEA Economics of Children's Health and Wellbeing Special Interest Group webinars, and it's a great honour to welcome Lisa Prosser, who's the Professor of and Director of the Susan B. Meister Child Health Evaluation and Research Centre at the University of Michigan. Lisa will be very well known to many of you. She's generated a significant body of research around measuring the value of childhood health interventions using various economic methods and decision science methods. And she's going to be talking to us about valuing health for children, adults, and caregivers. We'll follow the usual format, allowing around 40 minutes for the presentation and leaving around 15 minutes for discussion. Lisa's very kindly agreed to split the presentation into two, so there'll be an opportunity to ask questions and ask points of clarification partway through the presentation. But I think I'll suggest that we'll leave the bulk of the discussion to the end of the presentation. So thanks very much, Lisa, and over to you.
Great, terrific. Thanks so much, Stavros, for that kind introduction. Good morning, everyone. It's delightful to be here, and thank you, Kate, for organizing. It's nice to see many friends and colleagues joining this morning, especially those of you from the US, where it's essentially a holiday here. So it's really nice to see you, and especially in other parts of the world where I know I'm up against a World Cup game right now, which everyone else in my house is watching at the moment. So looking forward to having some discussion today. As Stavros mentioned, I'll be talking first about family spillover effects, and then about some work that we've done collaboratively with the CDC. And I see some CDC colleagues here on the screen as well. So I hope you'll join in during the discussion, and look forward to your thoughts and comments. So I'm going to go ahead and share my screen. Okay, is everyone able to see that? Yes. I'll take that as a thumbs up. Okay, great. Terrific. Wonderful. So actually, Kate, oh, okay, I was having some trouble advancing. I think there's just a slight delay. Okay, so in terms of the outline for today's talk, I'll be starting with an overview of family spillover effects in the context of economic evaluation. I'm kind of focusing on a brief summary of kind of where we are in the field today. And I see many spillover experts on the call as well. Look forward to your thoughts and comments. And then talking through some of the results from our case example of measuring quality losses associated with COVID-19 for children, adults, and family members. And then if there's time, I may share a few comments on newer expanded value frameworks that are being introduced in the context of family spillover effects. But I did bring a lot of material today. We may not get through all of that. And so just a preview there. So I just wanted to start with a very early example of when really my first introduction to family spillover effects, which was really quite coincidental. Back in the early 2000s, I was working collaboratively with the CDC in measuring values for preventing disease associated with pneumococcal infection as part of a cost-effectiveness analysis of pneumococcal conjugate vaccine. And at that time, there had been very little work done in valuing health utilities for children. And so we designed a survey, and our goal was to use direct elicitation to measure health utilities for children's health states, preventable health states associated with pneumococcal disease. And so as we went through designing and implementing this survey, our very first draft of the survey, we tried to apply a standard gamble approach, asking respondents who were adults to gamble a child life for child health. And so this is just a quick snippet of what chance of an immediate painless death would you accept, to avoid this health state, like in a child. And so we quickly heard back from our interviewers. We are actually doing this through a telephone survey, which we have only done a couple of times and no longer do because online is so much better for this type of work. But during that period of time, we were doing some of these by telephone. And so we heard back quickly from the interviewers that respondents were not able to respond to that question, that essentially they were not willing to take any gamble of a child's life for saving a child's health state. So we revised the question, we sent it back out into the field, we tried the time trade-off. We thought that might be a little bit more feasible for respondents to answer. But again, we heard from most respondents that they were still not willing to trade child time for child life. And so at that point, we did some additional pre-testing, talking with parents about how to frame this question. And we ended up creating a hybrid approach where we asked parents to trade off for the dyad. So considering, because what we were hearing from them was that it was very difficult to disentangle the effect of their child's illness from the effect on their own health state. And so we asked them, using a time trade-off approach, to trade off time for this dyad health state, both the child's health as well as the impact of the child's illness on the parent's health-related quality of life. And so that was really, and that's not an approach that we are applying currently, but it really was the first time that we started to think about family spillover effects and how are parents making these decisions and starting to consider effects among family members especially for a child's illness. So some other early work that we conducted in this area, also collaborative with CDC, was again using the time trade-off method. This slide shows an example of influenza health states, influenza-related health states, vaccine preventable. And here we asked for respondents to value the same health state, holding everything constant except for the age of the patient. And as you can see here, values were typically highest for the very youngest and the very oldest. And then so the question came up, kind of what's driving these values. And here, just to clarify, we weren't asking about a dyad health state, but the question was raised, is this a situation where kind of those spillover effects are entering the valuation process for the respondent? And I think this is an area, when we get to the end, that I think would be a nice topic for discussion, because I think that's an area where, at the current time, we are moving forward with trying to disentangle and to value these effects separately, the patient's health separately from family spillover effects. But I think many of us still have a concern that there may be double counting there when especially using the types of elicitation techniques that we're using currently. So now I'm just going to step back and just give kind of a very brief overview of family spillover effects in the context of economic evaluation, and starting with a few definitions. So these are effects that fall to the family, not solely to the ill individual, but are related to the illness or the treatment. They can be organized into three categories: direct costs, which can include both medical and non-medical costs, time costs for informal caregiving, and impacts on health-related quality of life for caregivers and family members. So direct costs can include any aspect of a treatment that's incurred at the family level, such as copays or deductibles for medical services, or non-medical costs such as transportation for a caregiver, or something as extensive as home modifications to accommodate a wheelchair. The term financial toxicity has also been used in literature to describe high levels of direct costs borne by the family. These costs can represent a substantial burden, especially for long-term chronic conditions. So effects on health-related quality of life can also be substantial. The category of spillover can result from caregiving, simply caring about others. Sorry, I've skipped a slide here. Hold on one sec. So time costs for informal caregiving can also represent a substantial burden, especially for patients at the ends of the lifespan. This table at the bottom of the slide is from the US, but demonstrates what an enormous proportion of individuals serve as caregivers. So 21% of all US adults identify as a caregiver, and the majority of these are caring for ill children or for older individuals. And just to clarify that this does not include general caregiving for children. This is in addition to general caregiving for children. Okay, so moving on to health-related quality of life. So in this category of spillover can result from caregiving, simply caring about others, or a combination of the two. And a number of studies have shown that the loss in health-related quality of life can be just as high for other family members as it is for the primary caregiver. Caregiver and family members can experience effects on physical and mental health, which can reduce their health-related quality of life as measured in health utility. Important to note that this can also result in additional health utilization for caregivers, which can then in turn be associated with additional direct costs to the family. The effect on health-related quality of life can vary with factors such as relationship status to the ill individual, characteristics of the condition, whether the relationship, such as a spousal relationship, is disrupted, and the age of the patient. And so this slide shows from some qualitative work that we've done, the different domains that are affected by spillover and stratified here by respondent caregiver status. And I think important to just clarify at this point that there are both health-related quality of life domains, so in the top half, but also many domains that are broader quality of life domains. And so if we have some time at the end, I think one of the the very important advances that's starting to happen in this area is thinking about not just health-related quality of life, but broader measures of well-being. And especially when we think about family effects, that it's important to consider broader measures of well-being as well. So just one final point on this slide, that if we look at the two columns between primary caregivers and non-caregivers, that the domains impacted are really very similar. Again, kind of underscoring that point that effects on family members who are not the primary caregiver can be just as high. So this slide shows domains affected by family spillover, but this time stratified by the relationship of the ill person to the respondent. And here you can see that there are some differences and especially high impacts on many domains when the patient is an ill child. This slide shows just a few quotes from some of the respondents in this study. And just to highlight here that while most of the family spillover is negative, so negatively impacting health-related quality of life, that on the right-hand side, I think important to recognize that there can be positive spillover. And we certainly heard this through qualitative interviews, such as patients saying it's brought us closer together. But really, the mass majority of spillover effects are negative. But I just think important to keep this in mind as well. In terms of impacting, including spillover in cost effectiveness analyses, there have been a handful of reviews that have evaluated how the inclusion of family spillover effects has impacted the results of a cost effectiveness or cost utility analysis. So one study by Lavelle et al. Evaluated 142 pediatric cost utility analyses, and of these, 72% did include spillover. Mostly these were time costs for informal caregiving, and inclusion of spillover typically yielded more favorable results. Another study by Lynn and others looked specifically at cost effectiveness analyses of interventions for Alzheimer and dementia. 70% of these considered spillover, again, mostly in the category of informal caregiving time. And inclusion, again, typically yielded more favorable ratios or remained cost saving. And then a third study looked at 40 cost utility analysis that included family member qualities. The inclusion of these also typically yielded more favorable ratios. Although, again, important takeaway from this group of studies here is that, well, first of all, there are not that many. And I would say that, there's an increasing number of analyses that are including these effects, but still they relatively few that include health-related quality of life impacts. But I think an important takeaway is that they did not always represent a substantial change in the ratio, that while they did become more favorable in terms of the overall result, they didn't necessarily cross a threshold value. And so just the next few slides, just to kind of characterize kind of where we are in the field right now. There are still kind of many, as much as many of us would be eager to include these effects in our analyses, especially in the context of child health, that there are still many data and method challenges. And so for any students and early career faculty, there is no shortage of topics that could use research in this area going forward. So with respect to direct costs, especially here in the US, and I'd be eager to hear if this is different in other countries, but we are really challenged by a lack of secondary data sources that include direct costs to the family. We have a few studies that for very common conditions that we can characterize family level costs, family burden, but typically we're collecting these data using primary data collection for specific studies when we're including them in a cost effectiveness analysis. Also, we have a lack of comprehensive data on informal caregiver time, although there's emerging data in this area, as well as alternative approaches to measurement and valuation. I think I saw Scott Gross on the screen somewhere, but Scott and others published an excellent review of the methods that are available for the measurement and valuation of informal care time a couple of years ago. And on the, in terms of measuring health-related quality of life spillover, a systematic review that Eve Wittenberg and I conducted a few years ago identified studies that use both direct and indirect methods. And I think there is, at this point, a lack of standardization for the valuation of spillover effects. So work to be done there as well. There are some of the other questions kind of at the forefront of the field right now are questions around equity. So I saw Harith Al-Janabi on the call as well. So equity questions of investing in caregiver burden or patient health. So when we start to include, not just one, potentially many family members into the economic evaluations, it's easy to see how kind of an intervention that eases caregiver burden or family burden could potentially result in a very favorable investment, while the patient's health may not be impacted much at all. And so there's a question about, is that really what we're investing in? I think there are questions, there are clearly some interventions that are caregiver specific interventions. And so, of course, that's a different question. But when we're evaluating interventions, for a specific individual, but most of the impacts, are on other family members. Seminal work here by Harithal Janabi and others looking at how respondents weighted caregivers and family members' quality of life compared to the index patient, I'll call them, for the analysis, and clearly provided lower weights for those values. I think that this is crucially important for us to keep in mind, as we're thinking about using these analyses and resource allocation decisions. Another critical question is how to define a family and where to draw the circle. There are many different ways that we can define a family: biological, legal, through legal relationships. Are they living in the same household? As we move further out to the edges of that circle, almost certainly the spillover effects will be smaller. But when do we decide to include or exclude those effects? Are questions that remain to be answered. So I am going to pause there. I'm going to unshare my screen just for a minute. So that's kind of the first section on kind of where we are in terms of family spillover effects. And just see if there are any comments. I know there are many of you on the call here today that are working actively in this area as well. So any clarifications, questions, or anything you'd like to open up for discussion for a few minutes at this point before we move into the COVID example.
Please feel free to raise your hand or use the chat function if you want to ask a question or make a comment at this stage. Harith, do you want to come in?
Hello, Harith.
Hi, Lisa. Thanks very much for that really nice overview of the field. I guess just one of the sort of questions you posed us maybe working in the UK or European context was about sort of collection of cost data from carers. And I think one of the things I suppose I've been surprised about is that, as you said in those reviews, that when carer spillovers are typically collected in economic evaluation, it's invariably on the cost side. And obviously, if we're doing a sort of societal perspective, that's sort of clearly relevant. But a lot of our work's sort of done under a payer or healthcare perspective, when those sort of indirect costs that might fall on the family or carers would be excluded. So I guess there's been less of a push from decision makers in the UK and maybe some other contexts to collect that sort of cost data from carers and family members. But I think some colleagues, possibly Donna is on the call as well, have done some work looking at whether you can use patient EQ5D data to kind of predict the likely sort of cost burden on carers in terms of time use and caring days. So I think that might be an interesting way forward, where it's hard to prospectively collect cost data from carers and family units. And so yeah, that's sort of just my thought on it. But yeah, nice overview. Thank you.
Great, thanks very much for those comments. That is a similar condition here in the States as well, that kind of our recommendations, from the second panel on cost effectiveness in health and medicine for the healthcare sector perspective, would not include direct costs to the family as part of that analysis, but would include health-related quality of life spillover effects if we had those data to incorporate into the analysis, but we don't always have that. I think the work that's being done around creating algorithms where we can estimate those impacts based on EQ5D or other data that's more easily available, will be a really important way forward, because we won't be able to have direct data on all of these. Great, thanks so much for those comments. Donna, did you want to comment? I see you on the call there. I don't want to call out anybody. So
no, I don't think so. I was just going to say the work that Harriet just mentioned, it's been kind of replicated using similar work in the Netherlands, I think, as well. So I think it's been done in a few different countries.
terrific. Thanks so much. Thanks. Oliver.
Hi, Lisa. Thank you very much for the presentation so far. And I just wanted to, it's a clarification also on experience on working in trials and trying to collect information from family members beyond the mother in the perinatal health. And in our area is a constant tension between the health economist and the principal investigators about burden for families. So I wonder whether, and to be honest, I've been terribly unsuccessful in many trials where there's a reluctance to collect information about fathers or siblings beyond the mother. So that's one aspect on how we could potentially improve that. And then it's a question about whether spillover effects might be important in some contexts and not others. And maybe we could potentially have a sort of some guidance on how to correctly understand. I mean, so for some cases, it's very clear there's the difference between having a severely sort of a baby severely compromised at birth, and then the baby is disabled for the rest of their lives, or something that is more acute. But something on those lines as well can help balance about how to collect that data more appropriately and how to incorporate that in the discussions that we have here, at least in the UK, in the context of trials.
Yeah, that's an excellent point, or several excellent points. So first, I think, to be able to create some guidance around how we can characterize where a burden is likely to be highest would be really important going forward. In the review that we did a few years ago, it was striking that many of the health utility values seem to cluster right around the 0.03 magnitude, which I think, we don't have a full universe yet, but I think there, maybe there is kind of a a standard level of spillover, but kind of an average level for many conditions, that we could impute. But I think that, these techniques that Donna and others are developing to estimate based on EQ5D or other measures of either health status or family health status are really crucial. I do want to just comment briefly on the challenge around incorporating this data collection into clinical trials, because I think, looking at the time, I won't get to the very last part of my prepared remarks around expanded value frameworks, but I did want to just comment on, that for many of these frameworks, the expansion is really on the value to the patient and is expanded value, similar to what you are characterizing for the clinical trials, from the health benefit side, but is not considering how that may impact burden on the family. And I think that when we think about these expanded value frameworks, we should be thinking about the other side of the valuation exercise, the cost side, the harm side, that part has not been expanded yet. And so I think, there is here in the US, PCORI, the Patient-Centered Outcomes Research Institute, has shared a framework for characterizing family burden, and that's an area that they're investing in now. And so at least here, they seem to be the only organization that's really investing in that flip side of the valuation framework. So I think that I'm really glad that you raised that, because I don't think we'll get to that at the end. James.
Hi, thank you. I am a big fan of your work, and I am working on spillover effects currently because I worked on child mental health and spillovers in clinical trials. And one issue that well, there are a number of issues that I'm writing a paper about currently, but one is that, first of all, I'm struggling with a lot of our terminologies that people refer to spillovers or family effects or externalities, which almost qualitatively devalues the direct health effects which are happening. Do you think we need to pull more from the psychological sciences and their ideas of social contagion, empathetic distress, to be quite more specific about the types of spillover which exist? And furthermore, I've been struggling a lot with, so I'm currently based at an MRC unit which runs a large cohort study in the UK. And something that I found is that health economics measures, particularly in life course cohorts or anything that's regularly collected for life course inference, is extremely low. So I'm trying to encourage people to include more measures here, but it's a huge challenge. Whereas conversely, the clinical trials that I worked on, much more shorter time horizon, primarily for kids going through the mental health care system, have fantastic data. But for these sensitive populations, the data sharing agreements are very, very stringent, such that other researchers may not make use of this, even though it might be extremely relevant to yourselves, for example.
Yeah, thanks so much for sharing those points. I mean, that is absolutely essential, and I couldn't agree more. It would be important to both to better characterize what the types of spillover are, but to think about how we can engage and pull in learning from the psychological sciences. And that actually is a perfect segue into the work that we did on COVID, because, for developing those health state descriptions, we ended up departing from kind of standard best practices for developing health state descriptions for health utility measurement. So I think I'm going to move into that, and then I hope we'll come back to this discussion again, and I'll be sure to leave time at the end. So thanks so much for those comments. All
Thank
right.
you.
I am going to share my screen again. And don't worry, Stavros, I'm keeping an eye on the time. I'll be sure to leave plenty of time for a discussion at the end. Is everyone able to see that? I know I'm not in slide sharing mode yet. Okay, so I've got a lot of detailed slides here on our methods. I'm not going to go through those in a lot of detail, but because I do really want to share kind of our approach to the health state descriptions and then the results, and then open it up for discussion again. But so just to set the stage, so this, the beginning of the pandemic, we were working with the CDC. We were about to put a survey into the field to measure quality losses related to RSV illness. But given how similar those health states were to COVID, at least, COVID that did not result in hospitalization, we were really concerned that there would essentially be contamination. And so we held the survey. What we ended up doing was, okay, my slide says COVID-29, apologies. That's let's hope we're not going to have a COVID-29. This is COVID-19 illness. That what we decided to do was to incorporate COVID explicitly into the survey. So we collected health preference valuations on both COVID-19 illness health states as well as RSV health states in the same study. We labeled the health states. Here's my disclosure that findings and conclusions are those of the authors and do not represent the official position of the CDC. I do want to acknowledge my research team. This was a huge collaborative effort. This is the core research team here. There are many others that actually helped us in the development of health states, especially with the COVID health states. But so what we ended up including in the survey was a number of health states, both for adults, children, and a spillover frame. We included 8 COVID health states, as well as 4 spillover health states. We only included spillover health states for children in this survey. We had limited space in the survey. We're actually about to put another survey into the field right now, where we'll be collecting spillover data on both working age adults as well as for older individuals. And so we're looking forward to seeing how those look compared to our original data that we collected in 2021. So I'm just going to skim through some of the methods so that we have time to get through the results. We use time trade-off questions, modified bisection approach to elicit time trade-off amounts where we had initial bid followed by a second bid, either higher or lower based on what the respondents had indicated to the first bid, followed by an open-ended question: what is your maximum amount that you'd be willing to trade off? And this is based on similar approaches that have been developed for contingent valuation to elicit willingness to pay amounts. This slide shows the bid vectors. These are derived based on earlier studies we've done, and also we conduct a soft launch where we field the survey on a portion of the overall sample, and then we go back and look to make sure that the bid vectors are covering the responses that we're getting. For the survey instrument, again, just kind of a quick overview here that there was an introduction as well as a practice time trade-off question. Each respondent then answered 6 time trade-off questions. So 2 health states with 3 frames. So answering the question, how much time they would trade for their own illness, then for the same illness in a child, then imagining themselves as a family member of an ill child. We asked a bunch of demographic questions. We also asked a number of questions around COVID-19 beliefs and attitudes, so vaccination status. This was fielded in May of 2021. So either vaccination status or whether people intended to get vaccinated, because there was still some queuing at that point, whether they had experienced COVID illness, either themselves or within the family, and then kind of what their level of concern was about COVID. Especially here, there was such polarization around attitudes towards COVID illness. We were interested to see if that actually would impact valuations for the health states. Just a preview there, we did not find much in terms of consistent differences when we stratified across these three attitudinal questions. So as we were developing the health states, and we developed them, in the usual iterative process, working directly with both patients who had experienced COVID illness, either themselves or in a family member, as well as with infectious disease physicians and critical care physicians who are treating patients. We made a few intentional design changes. So one is that we labeled the health states. Again, remember, like our original frame for this was we were trying to elicit health preferences for RSV related health states. And so we wanted to be able to distinguish them from the COVID illness health states. And so we labeled the health states. We also incorporated uncertainty into the COVID health states. It was clear as we were developing these health states that that was clearly part of the illness, for both the person experiencing the illness as well as the family member. We also included, and I think this relates to kind of James' questions, we included effects beyond the individual, and I'll give an example in a minute in terms of transmission. This is not transmission in terms of, if we have a dynamic transmission model where we're modeling the health impacts of those that are infected downstream, but this is the worry about potentially transmitting the illness to a family member or to others. And then we also heard a lot, especially in relation to child illness, health-related quality of life effects related to isolation. And so we built those into the health states as well. And so here, these are 2 examples of our outpatient health state descriptions for an adult and a child who has kind of, uncomplicated COVID-19 illness, and where we made some departures. Again, these are labeled in the survey as COVID-19 illness. And so in the 3rd bullet point, you don't know when you'll get better, and there is a chance that your illness will worsen and you'll need to be hospitalized. And then a little bit further down, you're contagious to other people and must remain isolated in your room without any contact with your family or friends. And same, we tried to keep things as parallel as possible for across all of the health states. So we did incorporate those into the health state itself. And I think just in terms of, well, I'll hold that thought for a moment and just kind of go through kind of what we did. So same thing for hospitalization. You don't know whether your treatment will work. There's a chance your illness could worsen, that you would require ICU care, a ventilator to help you breathe. You're alone during most of your hospital stay. Your family cannot visit you because you could infect them with COVID-19, and all hospital staff must wear full protective clothing. And similarly for children. And then I won't go through the rest of these examples, but we carried those throughout all of the health state descriptions. And then just a quick overview of the time trade-off questions. So again, the cadence of the survey is that we asked respondents first to consider the condition, whatever specific health state for themselves. Then for a child, and here we framed it as your child. At the beginning of the survey, we include introductory language around, if you do not have a child, or if you do not have a young child, think about a child or a relative's child or a friend's child. And then at the end, we did ask respondents also a little bit more information about the child that they were thinking of. And then the third frame is spillover. So thinking about yourself, like if your child is ill. So for survey administration, here we used a really high quality panel here in the US. So this is a probability-based panel, which is representative of the national US household population. And households are randomly selected using area probability and address-based sampling. And so this is the highest quality panel here in the States. And so it was conducted during April and May of 2021. Completion rate was 30%, which is quite good for online surveys. And we had a sample size of about 1,000. I'm not going to go into the respondent characteristics, except to say that they roughly match those of the U.S. adult population. But as we often find in online samples, even in this a very high quality sample, a little bit higher education and a little bit higher household income than the national average. For our analysis plan, we excluded respondents who indicated low confidence in their responses. So essentially, we asked some questions at the end, asking about how confident they are in their responses. And one of the responses is, my answers were total guesses. So those are respondents we typically exclude from the analysis. We did a number of analyses. I'll just be presenting here today, focusing primarily on the QALY losses, which we derived using maximum time trade-off amount divided by life expectancy. We conducted a number of secondary analyses. I gave a quick preview there. We didn't see much in terms of the stratification, the stratified analyses. And we also conducted some regression analyses to understand if there were any respondent characteristics that were systematically impacting the time trade-off results. So this slide just shows the exclusion rules that we used for those that are excluded from the primary analysis. We did run a number of secondary analysis where we exclude respondents based on different decision rules. I'm not presenting those here today, though. Okay. So this slide shows, and I'm actually going to move this is just a graphical representation of the table on the previous slide, which we can refer to if there are questions that come up. But these are time trade-off amounts for COVID-19 illness, outpatient, hospitalized, hospitalized with ICU or MISC for children, as well as long COVID. And as you can see, the pattern for these are mean time trade-off amounts are very similar, that highest for children. And again, we tried to keep as consistent as possible in the health state descriptions. And next highest is family spillover for children. And so these are respondents, again, like they're responding to all three frames in the same survey, and so they are consistently reporting more time traded for the spillover effect on themselves for a child being ill than for having that same illness in themselves. For quality losses, again, this is just translating those mean time trade-off amounts, dividing by life expectancy. And so here, not surprisingly, we see the same pattern, but this is represented in terms of quality adjusted life years lost. This slide translates into quality adjusted life days, just as a way to think about kind of what what is the metric that that we're considering when we're incorporating these into a cost effectiveness analysis. And I think what's really striking here is really how much impact on how much impact respondents are characterizing for the spillover health state. So for an outpatient illness, and again, this was time limited in our description, although there was that uncertainty that was built into it. 13.2 quality adjusted life days lost for hospitalization, 21.8 for and for a complicated MISC hospitalization, almost a month of time. This just shows the same information graphically. So just kind of in trying to characterize these in terms of how they compare to other conditions that we've used similar methods for. We haven't collected spillover states for all of these, but looking at just the adult and child health states for outpatient and hospitalized, that you can see that comparing to COVID-19 and influenza, that that the quality losses are consistently higher. Interestingly, for the for most comparisons, for the RSV uncomplicated outpatient health state, the adult values are really quite similar. The mean value is 0.019, and so that is we have some hypotheses about what's driving that. And my main hypothesis is that I think that despite our best efforts at trying to ask respondents to disentangle RSV from COVID, that given that time during which the survey was being fielded, that it could have been very difficult to really completely exclude that when thinking about valuations for these health states. But again, we're about to put a second survey into the field that's focused primarily on spillover health states. And we have one health state that we're linking across these two surveys, which is this adult RSV and COVID health state, so that we can directly compare what differences there might be now when we're in a very different time in terms of the surrounding pandemic, and to test to some extent if that could have impacted the values there. So I'm not, as I previewed, we really didn't see many differences here, maybe some differences in the direction that one would expect, but not consistent across all health states. And so I want to just come to the end and just summarize so we can open up for discussion again. So in summary, we identified higher losses associated with child health states compared to adults. Losses were higher compared to influenza and most RSV health states, but not all. Stratified analyses higher in many cases for those that were more concerned about COVID-19 illness compared to those who were not, but again, not consistent across all health states. We haven't done any regression analyses on this particular piece yet. And less pronounced differences for vaccination status or intention to vaccinate. Regression analysis, again, for our preliminary analysis here, we didn't see an association in the regression for those variables in the stratified analysis. And again, for comparing to kind of a broader universe of kind of spillover states, there are, we still have limited data to compare against. There's more work to be done there. So just in terms to kind of summarize kind of where we are in terms of implications for economic evaluation, I think that especially for COVID-19 illness, these intentional design changes on which we incorporated can capture the impact of concerns regarding future health. And I think that's where, because as someone who also does modeling, that prior to this, my initial approach would have been that, well, we're capturing that by incorporating the downstream health states and complications, into the cost effectiveness analysis. But I think that, this point around incorporating uncertainty and worry, that's actually part of that initial health state. And so we're not double counting by adding that into the health state description and incorporating it into that part of the analysis as well, because that second or downstream health state, has a separate set of attributes and domains that will be considered at that stage in the analysis. I think isolation, where, when we think about kind of expanded value frameworks, this is where, 2 years later, it's so clear that especially for children, the isolation and the impact of disrupted schooling has impacts well beyond the health sector that we don't even know to what extent those will be yet, but to start thinking about how to incorporate those into our economic evaluations as well. I think there are broader implications, not just from COVID, but for any other conditions that really disrupt schooling. And again, just back to this point that I touched on earlier, that I think the pandemic setting highlighted the need for our evaluation frameworks to extend beyond health-related quality of life to more fully capture other aspects of well-being. So we have about 7 minutes left. So I'm going to stop sharing there and open it up for hopefully additional discussion and questions.
Thank you, Lisa. Thanks. There's an opportunity now to ask further questions or enter a comment into the chat function. I think whilst we're waiting, perhaps I can, for others to come up with questions, perhaps I can start by asking Lisa. It's really interesting presentation. I wondered about whether, in terms of you've demonstrated higher utility decrements associated with child health states or greater sort of health-related quality of life losses. But in any of your work, have you disaggregated that by the age of the child? Are you able, or is that?
Yeah, thanks for that question. So we in other studies we've looked at different ages. Often we look at kind of 1, 8 years and 15 years, kind of look at, very infants and children compared to school age, compared to adolescents, and typically see highest values assigned to the very youngest children, that there is typically kind of not a linear relationship, but highest for youngest children, then for school age, and then for adolescents, which can often be quite close to adults. We didn't do that here just because we were really constrained in terms of our resources for the survey. It's always a trade-off on what you can include in terms of in terms of the number of health states that can be incorporated. So what we did do is we asked respondents at the back end, how old was the child that you were thinking about. And so we're also evaluating those data, but we haven't reported those yet. And so, but we do have those data.
Yeah.
But I think, the challenge is there is that, we haven't randomized. So we don't have kind of equal, samples across different age groups.
Yeah. That's really interesting. Donna, did you want to come in?
Yeah, it was really interesting, Lisa. Thank you. I really enjoyed it. I have a really boring question to ask about. It looked as if you'd got different time lengths across some of the vignettes, essentially. So it seemed that some of them, like the milder ones, seemed to last more like 2 weeks, where some of the hospitalized one was much longer, and so forth. Did you specify how long that lasts for? Because I noticed on your analysis slide you'd taken into account sort of the days that were described, I think, in the health state descriptions. And when you've done your analyses, have you done something fancy to kind of account for that?
So I'm really glad you asked that question, so that it's well, maybe not boring, I think, for anybody here, but we characterized the length of the health stay, and it was 2 weeks. I think for the outpatient health stays, and then varied depending on the intensity of the hospitalization, because we had several different hospitalization health stays. And then for long COVID, we specified 4 months, which was the best that we could kind of do at that time. Like, there was so limited data on long COVID. I think we would have, we certainly would have done that a little, or defined that a little bit differently now that we have data. But I think, one thing important to keep in mind is that this is in the context of temporary health states, and that, I would say as a field that we're still kind of relatively limited in terms of, how we value those health states, that, and especially for the approach that we use for the COVID health states, where we incorporated this uncertainty. So just kind of to anticipate where I think you're going, is that for some of those, the number of quality adjusted life days traded off exceeds the length of the health state. And so do we think that that really means that somebody is valuing that health state as worse than dead? I would say no, I don't think that's the case. But I do think that they're incorporating other aspects of health and potentially considering spillover even in that individual health state. And so that's where I start to get a little bit nervous about when we're just simply adding these together in, in a cost effectiveness analysis, because like my concern is that there's some of that that's already being incorporated into the valuation of the health state itself. And that we do typically see this, that, well, not typically, but in some cases we will see that the quality adjusted life days for a short temporary health state will exceed the length of the health state itself.
Thank you. Thanks. There's probably time for one more question before we finish. Okay, well, we'll probably wrap up there, and thank you once again, Lisa, and we'll reconvene with the webinar series in the new year, and you should receive an email about the next webinar. But thanks very much again, Lisa.
Great. Well, thanks very much. And thanks everyone for the great conversation and questions, and hope you have a terrific day. And for those of us here, happy Thanksgiving.
Yeah. Bye for now.